Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Professor Satoshi Kuroda. Prof. Kuroda is the professor and chairman of neurosurgery at the Graduate School of Medicine and Pharmaceutical Sciences at the University of Toyama, Japan. He is a vastly experienced neurosurgeon who specializes in the management of cerebrovascular diseases, especially occlusive carotid disease and Moyamoya. He has published more than 280 articles in various peer-reviewed journals, and he is also a member of the editorial board of several reputed neurosurgery journals. We are extremely honored to have him today at our webinars, and today he'll be talking about 5-year stroke risk in asymptomatic Moyamoya disease data from the asymptomatic Moyamoya registry. The speaker for the second session of today is our honorable guest from China, Dr. Li Pan. Dr. Li Pan is a chief neurosurgeon and director in the division of neurovascular surgery and endovascular neurosurgery at the Wuhan Brain Hospital. He is also the professor of Southern Medical University in China. He is an expert in the field of endovascular neurosurgery and has published several articles in various peer-reviewed journals. We are extremely honored to have him today at our webinars, and today he will be talking about endovascular treatment of MCA aneurysms. The chair for the first session of today's webinar is our honorable guest from China, Professor Shubin. Prof. Shubin is the professor of neurosurgery at the Huashan Hospital, Fudan University, Shanghai, China. He is also the vice president of the ACNS and is a world-renowned expert in the field of cerebrovascular diseases and also has the largest number of bypasses for Moyamoya disease. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Japan, Professor Kenichi Haraguchi. Dr. Haraguchi is a senior assistant professor in the Department of Neurosurgery at the Fujita Health University Bantane Hospital. He was previously working with the Department of Neurosurgery at Sapporo Teishinkai Hospital and also the Nagoya University Hospital. His clinical interests are focused on the endovascular management of cerebrovascular diseases, and we are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Shubin.
Okay, Professor Karuda, Dr. Raja, dear audience. I'm very honored to chair this session. Professor Kuruda is a very famous researcher for Moyamoya disease. And actually, I learned a lot from him, and he is also my very good personal friend and a big brother of mine.
Yeah.
So, so now let's welcome Professor Karuda to introduce his experience in the asymptomatic Moyamoya disease. Professor Karuda, time is yours.
Thank you very much, Raja and uh, Professor Shubin. I'm very glad and very proud to be invited to this ACNS webinar here. So now Professor Shu told I would like to present our recent result about a cohort study of asymptomatic Moyamoya disease. Actually, this study is partly supported by the Ministry of Health, Labor, and Welfare, Japan. And this is a photograph of Japan Alps near my home city, Toyama. Our research committee on Moyamoya disease was established in 1974. So now our group is 50 years old. Last year, 50-year anniversary of our research group. And here is a list of our group head for these 50 years. Probably you know Professor Hashimoto, Yoshimoto, Professor Hawking, Professor Miyamoto, and since April 2024, I'm the director of a research group. You know, we conducted a JAM trial, a Japan adult Moyamoya trial, to clarify the effect of bypass surgery on hemorrhagic Moyamoya disease. We started JAM trial in 2001, so about 25 years ago. And we finalized this study 2013. And since then, we have published totally 8 papers about hemorrhagic Moyamoya disease. After this JAM trial, we have conducted many multi-center clinical study on Moyamoya disease in Japan. This is a list of multi-center clinical study on Moyamoya disease conducted by our research group. We started asymptomatic Moyamoya registry, AMORE study in 2012, and we will finish AMORE study at the end of this year. And there are many other clinical trials in Japan. Some have been finished, and some are ongoing, and some are planning from this year. But anyway, I'd like to focus on AMORE study today. You know, bypass surgery is quite effective for symptomatic Moyamoya patients. The patient with ischemic event or hemorrhagic event should undergo bypass surgery to prevent their future stroke event. And Professor Xu is performing many bypass surgery for Moyamoya patient in China. I really respect him. But we do not know how to manage asymptomatic Moyamoya patient yet. How do you think about it? Should we just follow up the patient, or should we perform a bypass surgery even for asymptomatic patient? We don't know it. There is no clear evidence about it. But probably due to a widespread use of MRI and MR angiography, the incidence of asymptomatic Moyamoya patient is rapidly increasing for these 30 or 40 years. This is one example of asymptomatic Moyamoya patient. 50 years old guy he was diagnosed as asymptomatic Moyamoya disease after a very mild traffic accident. MR angiography is very typical for Moyamoya disease, and he had remarkably developed Moyamoya vessels from right lenticular arteries. 5 years ago, he developed a hemorrhagic stroke. You can see the hemorrhage occurred from the markedly dilated LSA channels. Another example of Moyamoya, asymptomatic Moyamoya patient, 50 years old female. She had just tension type headache, but she was diagnosed as a Moyamoya disease, asymptomatic Moyamoya disease. These images were taken at the initial diagnosis, but 5 months later, only 5 months later, she developed right hemiparesis and motor fascia, and MR angiography revealed very rapid progression of disease stage at the on the left side, like this. And very quickly, she lost consciousness, and a big infarction occurred. And we performed decompressive craniectomy, but she was deceased due to brain herniation. So we know asymptomatic Moyamoya disease is not a silent disease. So about 20 years ago, when I was very young, we conducted a very small multi-center cohort study about asymptomatic Moyamoya disease. This paper was published in 2007. In this study, we enrolled only 40 asymptomatic patients, only 40 patients. I think at that time I was very young, so I couldn't enroll many patients. But anyway, in this study, 34 patients were medically followed up, and 6 patients underwent bypass surgery, because this study was not a randomized study, but just a cohort study. Anyway, of 34 medically treated patients, 7 patients experienced TIA or ischemic stroke or hemorrhagic stroke during about 3.5 years. So tentative conclusion showed the annual risk for stroke was 3.2%. Very interestingly, 6 surgically treated patients didn't develop the cerebrovascular event. But from such small volume studies, we cannot reach a final conclusion. So at that time, I wanted to conduct a larger volume cohort study about asymptomatic Moyamoya disease in the future. This chance has come in 2012. We could start this AMORE studies, asymptomatic Moyamoya registry, and we decided to enroll a much more asymptomatic patient and follow up them for a much longer time. Finally, a 10-year follow-up was aimed this time. But anyway, so 10 years follow-up of all patients will be finished at the end of this year. But anyway, we summarized the result of 5-year interim result of this study. The study design of AMORE is multi-center prospective cohort study. And you can see the inclusion criteria, 20 to 70 years, and bilateral or unilateral Moyamoya disease on cerebral angiography or MR angiography. And also they had no episode suggestive of TIA, ischemic stroke, hemorrhagic stroke, and involuntary movement. And their activity of daily life was well. Now we set primary endpoint as ischemic or hemorrhagic stroke. And the secondary endpoints included TIA, silent cerebral infarction, silent disease progression, silent microbreath, and any death. We collected, of course, the demographic data, medical data, laboratory data, and radiological data, including T1 image, FLAIR image, T2 image, T2 star image, MR angiography, and if possible, cerebral angiography. And we decided to collect the data each year for 10-year follow-up. And the patients were enrolled between 2012 and 2015. So we will finish a 10-year follow-up of all patients at the end of this year. During a 4-year enrollment period, Totally 109 patients were enrolled from 18 hospitals. During first 5-year follow-up, 6 patients were lost because they moved to another place. So we completed 5-year follow-up in 103 patients. Here is a demographic data of 103 patients. You know, there is a female predominance in Moyamoya disease. This is almost same. And mean age was around 44 years. This is very similar to usual Moyamoya disease, you know. And there was not so many comorbidities, including hypertension, diabetes, and hyperlipidemia, and so on. And familial occurrence was confirmed in about 20% of patients. Radiological data at the enrollment, cerebral infarction was identified in 12% of hemispheres. The predictor of cerebral infarction included advanced disease stage and also PCA involvement. Intracerebral hemorrhage was confirmed in 6% of hemispheres. Microbreeze was same, and the PCA involvement was seen in 70% of involved hemispheres. And a decreased cerebral blood flow was confirmed in about 1/3 of hemispheres. Very many. During the 5 years follow-up, 7 patients developed a stroke. This image is CT or MRI at the onset of stroke in each patient. 6 patients developed a hemorrhagic stroke, and only 1 patient developed ischemic stroke. When I started this study, I expected that ischemic stroke will be more frequent than hemorrhagic stroke. But the result was completely opposite. This is a Kaplan-Meier curve of stroke during 5 years. And multivariate analysis demonstrated that grade 2 colloidal channel was only one significant predictor for stroke. Hazard ratio was around 5. Grade 2 means markedly development of periventricular anastomosis. So grade 2 choroidal channels means very dilated Moyamoya vessel in the territory of choroidal artery. On the other hand, hemorrhagic stroke, six patients developed hemorrhagic stroke, and the predictor of hemorrhagic stroke included again grade 2 choroidal channel and also microbleeds at the enrollment. Hazard ratio was 7 and around 5 respectively. Very high hazard ratio, I think. This is a summary of a predictor of hemorrhagic stroke. Microbleeds at the enrollment is a predictor for hemorrhagic stroke in the future, and also such very dilated choroidal channels is another strong predictor for hemorrhagic stroke in asymptomatic Moyamoya disease. When we divided the patient into two groups, one group is a grade 2 choroidal channel, and another group is the non-grade 2 choroidal channel. There are significant difference in the occurrence of hemorrhagic stroke. So how about secondary endpoint? Very surprisingly, annual risk of disease progression was around 6% per person per year. And the risk of TIA was 2.3% per person per year. And new development of microbleeds occurred in 2.3% per person per year. So I was very surprised to know that the incidence of secondary endpoint is much higher than I expected. This is two examples of disease progression. In case 1, the right side disease stage markedly progressed only 1 year later. Very similarly, in case 2, disease stage of on the right side progressed 3 years after the enrollment. And you can see the Moyamoya vessel more and more developed. This is two examples of new development of cerebral infarction. Two years later or 5 years later. But the incidence of cerebral infarct development was very low, only 3 cases. This is an example of de novo microbleeds 3 years later, 4 years later. The incidence of de novo microbleeds is very high. This is a Kaplan-Meier curve of disease progression, TIA, and de novo microbleeds. This is a result of multivariate analysis. The predictor for disease progression included a younger patient. Hazard ratio was around 6. And another predictor was hypercholesterolemia. Hazard ratio was very similar, 5.4. So we should very carefully follow up younger asymptomatic patient with high cholesterol level. Maybe we should check MRI and MR angiography every 6 months or every 12 months. The predictor for TIA was disease progression. Maybe you can imagine that disease progression can easily induce TIA. Hazard ratio was very high, and 7.8. And finally, the predictor of de novo microbleeds was microbleeds at enrollment. Hazard ratio was 5.5. It is quite natural, I think, because microbleeds can easily develop in patients with markedly developed Moyamoya vessel. So such patient can develop another microbleeds during follow-up period. The result of secondary endpoint has been published in Journal of Neurosurgery in October 2024, online publishment. It is not still published in the paper journal. So thank you very much for your attention. And take-home message is that 5-year stroke risk in asymptomatic Moyamoya disease is 1.4% per year. And the incidence of stroke, of hemorrhagic stroke, was much higher than ischemic stroke. And the microbleeds and grade 2 colloidal channel were very strong predictor for hemorrhagic stroke. And the disease, the incidence of disease progression, TIA, and de novo microbreeds was much higher than expected. And now we know the strong predictor for this secondary endpoint. So when we find asymptomatic Moyamoya disease, we should be very careful to take care of asymptomatic Moyamoya patient. We should check MRI and MR angiography very precisely, and also we should recommend them to come visit our hospitals every 6 months or every 12 months to check the any change on MRI and MRA. And if we find any dangerous change during follow-up period, we should consider the possibility of bypass surgery, I think. This is my tentative result. But anyway, we will finish 10-year follow-up very soon. So we would like to report final result of AMORE study very quickly. Thank you very much.
Thank you. Thank you very much, Prof. Kuroda. It was really interesting and we learned a lot today. Unfortunately, Professor Shubin has been disconnected, so we'll move on with the questions from panelists. I'll start with mine. Like when you said you should follow up these patients every 6 months, would you advise any medications for them to be on follow-up other than controlling diabetes and hypertensive?
I don't recommend antiplatelet for asymptomatic Moyamoya patient. No antiplatelet, because many patients developed hemorrhagic stroke during follow-up period. So if we give antiplatelet drug, they will suffer more severe hemorrhagic stroke, I think. And if asymptomatic patient have hypertension or hypercholesterolemia, we should treat such comorbidities with appropriate agent, I think.
Thank you very much. Any questions from my co-host, Dr. Libun Singh?
Yeah, thanks, Raja. Thanks, Professor, for a very nice lecture. I have a three question, Professor. Since you're detecting more asymptomatic Moyamoya due to the screening, just like what you have done for the aneurysm, would you now see there's increasing in the prevalence of detecting asymptomatic Moyamoya cases? And you mentioned that more than 45 years old are one of the predictor of identifying patient with Moyamoya. Would you now extend the brain scan to those with more than 45 years old in terms of to be able to follow up them more regularly, as what you mentioned? My second question, Professor, when you're detecting those patient with asymptomatic Moyamoya, do you think that the medication that modified the natural history of the risk of bleeding and also the risk of ischemic changes in those patients, especially related to treatment of hypercholesterolemia and also blood pressure. What I just wonder what is your target blood pressure, because your high blood pressure will cause bleeding, your low blood pressure will cause ischemia in them. So what is the recommended targeted blood pressure? My third question, Professor, regarding asymptomatic, and you mentioned that in your asymptomatic group there are patients that with microbleeds. So do you think that in the future we need to redefine the term of asymptomatic, whether we have enough tests to test the patient? Because you mentioned that patients symptomatic are those who with stroke, either hemorrhage or ischemic or TIA, and those without symptom are considered asymptomatic. Probably we have not defined the symptom enough. We have not done enough tests to see patient is actually really asymptomatic or symptomatic. What is your opinion regarding this? Thank you, Professor.
um, all your question is very good. Thank you very much. Actually, the incidence of hypertension was just 20%, and incidence of hyperlipidemia was around 12% in whole asymptomatic patients. So the incidence is not so high, and because most of patients are rather younger, 30 years old or 40 years old. So, mean age was around 45 years. So it's quite natural. But anyway, when we find such patient with hypertension or hyperlipidemia, we should strictly manage such comorbidity, I think. Especially hypercholesterolemia was a strong predictor for disease progression. So I think medical treatment should be very strict, I think. But now we are not checking the precise laboratory data of our patient. So you are asking ideal value of blood pressure and also cholesterol. But today I cannot answer to your questions. Sorry. But anyway, we should try to normalize all of data values of blood pressure and hemoglobin A1C and cholesterol, I think. Okay, and the definition of asymptomatic is quite difficult. Many reviewers always ask me, what is asymptomatic? How do you define asymptomatic? Many questions. So I think your question or opinion is quite natural, I think. But anyway, in this Amore study, we defined asymptomatic patient is a patient who did not have any symptom. So, but our opinion may be incorrect, I think, because if the patient had silent infarction or silent microbleeds, they may be symptomatic. So a definition is quite critical, I think. So we should divide the asymptomatic patient into the patient without image abnormality and the patient with image abnormality. And we should check the difference in the outcome between two groups. So your idea is very nice, I think.
Thank you. Thank you very much, Professor.
Thank you.
Thank you, Liu, for asking. We have a raised hand from Muhammad Helmi. He was, in fact, a resident of Professor Shubin. Yes, Dr. Helmi?
Yeah, thank you. Thank you, Professor Kuroda. That was a very impressive presentation. By definition, Moyamoya disease is a unilateral or bilateral progressive steno-occlusive diseases that lead to hypoperfusion, which trigger the formation of new blood vessels, which called Moyamoya. So, since the perfusion is the critical tool for the progress of this disease, do you think perfusion studies are important in evaluating the progressive nature of this disease? For example, if I have asymptomatic patient who come to my clinic, I think from angiographical point of view, it doesn't matter this patient have I was found him with early stage or late stage. Probably the guy with late stage has better perfusion studies than the one with the early stages. So do you think the perfusion studies like CTP or others is important in the evaluation of these progressive nature of the disease? Thank you.
Thank you very much. Very, very, very nice questions. When we started this study, we tried to collect CBF data from all participants. But finally, we could get CBF data from about 80% of patients. So in this analysis, we could not include the CBF data. But in another analysis, we checked the importance of CBF with only 80% of participants. So as a result, normal CBF and grade 2 colloidal channel were very, very strong predictor for hemorrhagic stroke. Low CBF was not predictor for any stroke. It was very unexpected result, but it may be quite natural because very dilated Moyamoya vessel is providing blood flow to the brain as much as possible. So CBF is maintained within normal limit. In such a case, the risk for hemorrhagic stroke may be very high. I think so. But unfortunately, my staff have not submitted this data. So today, I didn't present this result. So I will push him to submit the data the next week. Thank you very much.
Thank you. Thank you. Appreciate it.
Thank you. Nice question.
Well, thank you very much. That was wonderful. So now we'll move on to the second session, but before that, I would like to thank Professor Satoshi Kuroda and Professor Shubin for this very enlightening session. And we're extremely grateful to you for coming here and taking out your time to support the educational initiatives of the ACNS. Thank you very much. So we'll move on to the second session. Before that, I would like to mention that this has been broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 850 people who have logged in through all different channels. So we'll move on to the second session, and I will hand over this podium to our Honorable Chair, Professor Kenichi Haraguchi, who will say a short introduction about endovascular management of MCA aneurysms and invite Professor Lee Pen for his lecture. Prof. Haraguchi.
Hi, hello. My name is Kenichi Haraguchi. I'm working with Professor Yoko Kato at Bantan Hospital since the last April. So thank you very much for introducing me to the honorable lecture webinar. I was looking forward to join in this meeting. So today, today's second session is endovascular. This is nice to meet you, Professor Lee Pang. That I was also looking forward to see you. So the title is endovascular treatment of medial cerebral artery aneurysm. Thank you. Please, Professor.
Good evening, everyone. I will share my screen. Good evening, everyone. It's my great pleasure to speak here. Today, my topic is a single center experience of about the endovascular treatment of MCA aneurysm. As we know, the MCA aneurysm are among the most common types of intracranial aneurysms, account for 20%, and the majority of the aneurysm located at the bifurcation of M1 to M2 segment count 63%, and the early frontal branch and early temporal branch bifurcation account for the 18%, and the lenticular straight artery aneurysm account 13%, and distal aneurysm is rarely M3 and M4 aneurysm account 6%. The treatment strategy, including surgical clipping and endovascular embolization. Surgical clipping is a common treatment method, especially suited for the MCA aneurysm due to the accessibility, and the endovascular embolization is optimal option right now because the novel technique and the new devices. So it's minimally invasive. So in our center, it is always the first choice. And the endovascular embolization, including carding, stent-assisted carding, and flow divert in the web. So now we review some updated articles. The first article is about a randomized comparison between the surgical and the endovascular management. The endovascular group, 4 cases failure of a modality to treat, and 10 cases residual aneurysm at 1 year follow-up. And the surgical group, no cases failure, and only 2 cases residual aneurysm in long-term follow-up. So from the 2 RCT research, surgical clipping may be achieved the best, as a better efficacy. And the second article is about the pipeline embolization for complex wide neck bifurcation aneurysm. And from the table 3, you can see Perioperative complications. Ischemic is three cases, and hemorrhagic complication is one, not more than 9%. And the long-term follow-up complete occlusion is 97.6%. It's a really good outcome. So pipeline is a feasible and very safe device for treating the MCA aneurysm. The third article is about the endovascular treatment for rupture MCA aneurysm. The total case is total case is 118. Calling is 62, and nine cases have complications. It's amount to the 15, about 15%. And the standard assist coil is number 35, and nine cases have a complication. It's amount 26%, so it's really high. And the website is 21 cases, only one have a complication. It's only account for the 5%. So from this article, can see the web is a novel device. Is good and rather safe and feasible device for rupture MCA aneurysm. Now let me introduce our illustrated cases and in our center. The first case, male, 45 years old, SAH, 12 hours, admitted into our, and DSA shows a tiny aneurysms, located the bifurcation of an aneurysm, located MCA artery, and we use two coil to densely embolize the aneurysm. And 6 months follow-up, can see the aneurysm recur. You can see the aneurysm neck recurrent. And 5 days later, we coil the current aneurysm using the EP stent and one coil. And you can see the project. You can see the wide neck and densely compact. And 6 months follow-up, angiography, you can see no recurrent. So from this case, we know the stent can prevent the coil compaction and reduce the recurrence of the aneurysm. And the second case, a male, 60 years old, is sudden unconsciousness 3 hours, admitted to our department. 3D, you can see the aneurysm irregular and a side branch arising from the in one segment and the aneurysm. And the angle is an acute angle. So using blue assist or stand assist to cover the aneurysm is not feasible. So we're using microcatheter and microguide wire protection to the small artery. And firstly we coil the dorsec and coils the aneurysm one by one. See this coiling. And this is the first coil, the last coil. And then we withdraw the microcatheter and McGuire's the coil is stable. And the small artery preserved. So this is 3D. Because it's a rupture aneurysm, so I think it is okay for the last image for the embolization the aneurysm. So case 3 is a patient with multiple intracranial aneurysms. One aneurysm is located at the C4 segment, and another is the MCA aneurysm. So first we embolize the huge aneurysm, the huge aneurysm, using the space involved 4.5 by 30 millimeter. 6 months follow-up angiography, you can see the aneurysm, the joint aneurysm, almost complete embolized. Then we treated the bifurcation aneurysm. You can see we can put the stent here and put the inferior branch. But to select this artery is difficult because of the acute angle. So we use the open cell stent, address the dome technique. We use the open cell stent and give exchange here when deploy the stent, and the stent can protect the two branches. So and with the protection of the stent, the area against the package. And case 4 is a female, 47 years old, is releasing unruptured aneurysm, is diseased for 1 month, admitted to our hospital. And this is an impressive case for me. The patient have a small aneurysm located at MCA bifurcation, and they have a dissection in C1 segment. So firstly, we deployed EP2 to assess Carling's aneurysm. And I think the stent location is well, is precise the deployed aneurysm as a stent. And this is the last image. But we can find, because the M2 is smaller, much smaller than the M1 segment, and the stent mark is not open well. but we cannot do nothing at that time. The aneurysm was densely packed. And then we using the wall stent to treat the dissection, 7 by 40 milliliter, and it cost maybe 18 minutes. We finished the successfully deployed the stent. And after that, we found the stent migration to the from the M2 to M1, totally migrated into the M1 segment. This is right after the deployment of a stent. This is maybe about 20 minutes later. What caused it? I think it's caused the watermelon seed effect, because the big difference between the M2 branch and M1 segment, and the different pressure to the distal portion of stent and the proximal portion of stent, then generate great force to stent and cause the deployed stent migration. So from this case, I think maybe open cell stent is optimal selection, because closed cell maybe open cell cannot migrate it, because it's a segment to deploy it. Case 5 is another very difficult aneurysm to treat. This is the early temporal branch artery aneurysm. The early temporal branch is acute, is a small and tortuous and acute angle arising from the M1 segment. We're using the loop microcassette technique to navigate the guide wire into the small artery and advance advance the microcatheter into the artery. And then we deployed the open cell stent, neurophone Atlas 3x21. You can see it successfully deployed the stent, and post procedure image, you can see the small artery was well preserved, and the aneurysm was densely packed. This 3D rotational angiogram. Case 6 is always another tough case to embolize. It's a male, 34 years old. This is for 12. Is unruptured aneurysm. The aneurysm is absolutely wide neck, and the M2 branches and M1 branch. The shape is arrow shape or T shape. So you want to embolize the aneurysm using one single stent is impossible for me. So we using a kissing white stent technique. We select advanced two catheter into the two branches and deploy the stent in turn. So only we use two microcatheter, not three. So microcatheter to do that. I think it is insert from the stent into the aneurysm is really easy. So we insert the microcatheter into the aneurysm. Three sec. We one by one to embolize. So this is a 3D rotational angiography. You can see the removed one embolization. This is another wide neck MCA bifurcation aneurysm. It's unruptured aneurysm. So first we plan is to the single stent assist calling, but one single stent cannot protect the two branches. The coil always protrudes the superior branch. So now we navigate another microcatheter into through the stent, the first stent, into the superior branch, and we deploy the EP stent and densely occluded the aneurysm. This is crossing white stent technique. This is a 3D construction. You can see image. You can see no aneurysm is densely occluded, packed. This is another difficult case. 3D, you can see the early frontal artery bifurcation aneurysm. The artery is side branch is very small and acute angle and tortuous. So you will want a balloon assist or stent assist is not feasible. So we're using microguide wire and microcatheter protection. With the protection as a microcatheter, okay, we can embolize the aneurysm densely. This post-op procedure image. But 6 months later, the aneurysm recurred. This is 3D. You can see the recurrence. So using stent assist coil is not, I think it cannot successful. So my plan is deploy a flow diverter and decreases the blood flow to the small branch. And once the aneurysm shrunk, the stent position is good. And 5 months follow-up, we can see the aneurysm occluded, and the small artery branch were preserved. This another case is a lenticular striate artery aneurysm. Sorry. The aneurysm is irregular at a two duct sac, so it is a high risk of bleeding. The patients we're using a flow diverter, Nova 3 by 12 millimeter. This Nova stent is Chinese company flow diverter. This is post procedure angiogram. This is 3D construction image. 6 months follow-up, we can see the aneurysm much smaller than before. This is 3D, and the artery is well preserved, and no any ischemic stroke occurred. The case 10 is a large dissecting aneurysm located in one segment. The blood flow inject into the aneurysm, direct inject into. So just in case of the rupture and the high recurrent rate, we're using the flow diverter combined coils. This is the last image. But 3 months follow-up can see the aneurysm was completely occluded, but we found in the pipeline, we can see the instant stenosis. So we adjust antiplatelet therapy when we didn't do the angioplasty, and I think it caused the intima hyperplasia, and we stopped using the Plavix and change and uses the Ticarilla 45 milligram BID. So it need a long-term follow-up. The case 11 is a male, 28 years old, left limb weakness 2 days. I think this neurologic deficit is caused by ischemic stroke, and the aneurysm is difficult to treat. Is a dissecting aneurysm in the M1 segment and M2. So we deployed a pipeline 3.5 by 18 millimeter. The stent. The work application is good, and the 6 months follow-up, we can see the aneurysms we can see in good shape, much smaller than before, and all the branches are patent. No occlusion of small arteries. And now is for the this is a wide neck aneurysm located in the MCA bifurcation, and the aneurysm is really regular, not irregular, it's regular. So it is a good indication for the web device. So we deployed a web 5 by 3 millimeter. It deploys a web successfully, and we can see the web in good position, and the two branches were preserved. This 3D rotational angiography. 6 months follow-up, we can see the aneurysm totally occluded and the two branches preserved well. So web is good for this case, easy case, bifurcation, aneurysms. This is a very impressive case for me. This is a wide neck MCA bifurcation aneurysm, but the M1 parent artery M1 segment near the aneurysm have a severe stenosis. So just in case of ischemic stroke, we using a gateway balloon angioplasty before deploy the web. But after withdraw the balloon, we found the aneurysm ruptured. So we do research for this, for which site for the rupture. We found this apex of the aneurysm. So we quickly insert the via marcus and deploy the web. And the web stops the aneurysm bleeding, and this is the post-procedural angiography. This is CT at that time, and 7 days later, the patient have no neurological deficit, and 7 days dismissed from our department. So it is a fortunate case. The case 14 is another wide neck aneurysm. We use the web to MRIs. Firstly, we choose the 5x3 millimeter, but it is we tried several times. I cannot deploy the web, so we change a smaller 4.3 4x3. It successfully deployed the web, but the final angiography, you can see a small dog ear here. So the patient need a long-term follow-up. So 15 case is a male, 68 years old, is a sudden unconsciousness 10 hours, admitted to our hospital. CT shows ACH and temporal lobe hematoma. CTA showed regular wide neck aneurysm. So we deployed web 7x4. We spend not more than 1 hour to finish the operation. So for easy case, the web is very feasible and safe device. And this post-procedural angiogram, and this is lateral projection. After embryo deploys web, we do the hematoma puncture and drainage, and the patient regains consciousness, and 2 weeks later dismissed from our department with a mild neurological deficit. This is the last case. This is irregular wide neck MCA bifurcation aneurysm. You can see a dot sac crosses the aneurysm neck as an unruptured aneurysm. So we deployed 7 by 4 millimeter web. This post-procedural angiogram. The artery branches pretty well, and the web is the same size of the aneurysm. But we can see the web cannot totally cover the neck of the Dodge sac. So 6 months later, similarly follow-up can see the Dodge sac because maybe blood flow into the Dodge sac so a little larger than before. So we insert a microcatheter into the Dodge sac and embolize the Dodge sac. This is the last image. Here's 3 coils. So irregular web is maybe not feasible, not optimal for the web device. So all above is our experience in treating the MCA aneurysms. Now I'll summarize my PPT. First is a guide wire and microcatheter protection allow for precise navigation through tortuous vessels, especially good for the rupture aneurysms, ensuring acute coil placement and reducing the risk of coil migration. And the flow diverters offer a viable option for MCA aneurysms, especially when combined with adjunctive devices and meticulous imaging, particularly suited for patients with complex anatomy and those ineligible for surgery. So flow diverter is not good for the rupture aneurysm or MCA aneurysm. So web is a promising novel tool for treating complex MCA aneurysms, where traditional methods are less feasible. So web is good for the rupture aneurysm, and why can avoiding the antiplatelet therapy and be minimally invasive. Thank you. This is my work team. This is my talk. Thank you.
Thank you very much, Professor, for great technique, showing great technique and great lecture. So firstly, I would like to ask some question from me. So commonly, it is said that the coiling for the aneurysm has higher risk of recurrence compared to the creeping or web, especially in the larger aneurysm. So in our country, for middle cerebral artery aneurysm, the creeping is in many first hospitals in our countries, the creeping is the first choice for MCA aneurysm, and or in my hospital now we choose the web treatment in the first line for MCA aneurysm if the shape is okay for the web. So in your hospital or country, what is the order of the choice of the treatment for MCA aneurysm?
Sometimes aneurysm located at the MCA always in the bifurcation is wide neck is much frequent. But if the aneurysm with a big hematoma, always we choose the surgical clipping and evacuate the hematoma simultaneously. But if no hematoma and the hands less than 2 scale, we will choose the embolization. And first choice we use carding, not using stent. But if the wide neck, we always use a stent, and we in our experience know if we dense compact the aneurysm in our center, no bleeding after the stent deployment. So for my experience, I think for the acute rupture aneurysm, we can choose endovascular treatment. But always we don't use flow diverter. Web is a good choice because while web deployed, okay, we don't need to use the antiplatelet medication. So thank you for your nice question. Yeah.
Any other questions?
Yes, we can.
I have a question.
Barry, please.
Thank you, Professor, for your nice and vivid presentation. I have a question. In your number 15 case, you have shown that the MCA wide-necked aneurysm presented with ruptured and ICH. And my question is, if there is ruptured MCA wide-necked aneurysm presented with ICH and ICH having large or having significant mass effect, and what should be done first? In your case, you first did the endovascular treatment, then went through the surgery evacuation of the hematoma. And my question is, if the hematoma volume is large and there is significant mass effect, which should be done first? First evacuation or first endovascular treatment?
So a good question. So I not introduce the case very precisely. Firstly, before we do the embolization, we have a long conversation with the focal of the patient. My recommendation is do surgical clipping, but the focal of patient refuse to surgical crematoma. So we do this web device deployment. So if we meet the same hematoma, the large hematoma, MCA wide neck aneurysm, the first choice is we plan to clip it, not do endovascular treatment.
Thank you.
Mm.
Thank you, Professor.
Thank you very much.
Yeah.
Any other
Thank you very much. Question. Yeah.
Shakmat, any questions from you?
Hello. Yes, thank you, Professor. Hello, everybody. Thank you, Professor. It's a great lecture, wonderful cases. I would like to ask you about flow diverters. As you say, this is not preferable. You prefer mostly like web devices, and if you do flow diverter, for example, is there any differences in the antiplatelet drug medicine in comparison with the ICA deployment of stent? Thank you.
A nice question. So MCA play flow diverter is the last choice for us because a lot of branches there, maybe the long-term follow-up is the outcome is not good. Since ICA segment, just the C6, C7. So flow diverter is not for the rupture MCA aneurysm. It's a complex a lot other method is difficult to treat. We choose the flow diverter. Yeah.
Mhm. How about the antiplatelets? Like same as a as
the same as other place. We use aspirin 100 milligram 1 QD, and using the Ticarello or Plavix 100 milligram QD or BID 45 milligram BID. And we do coordination test before the operation. Yeah. Thank you.
for the resistancy of antiplatelet drugs. Yeah. Oh, yes, as I understand.
Yes. So I cannot hear very clearly. Yes. Sorry. Thank you.
Okay. Thank you, Professor.
I think if there are no further questions, we can call it a day and invite Prof. Haraguchi for his concluding remarks.
Thank you for great discussion, everyone. So now we finish this session. Thank you very much.
Thank you very much. We indeed had a very wonderful session. Now I'll close this officially on behalf of the Education Committee of the ACNS and the President, Prof. Kato. I would like to thank both the speakers of today, Professor Satoshi Kuroda and Professor Lee Pan, as well as the chairs, Professor Shubin and Professor Kenichi Haraguchi, for the time and support for the ACNS webinars. Very special thanks to our Honorable Vice President, Professor Shubin, for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 850 people who have joined us live across all the 3 different platforms. And also a very special thanks to my co-host Dr. Libun Singh from Malaysia, who has joined me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.